Good morning, doctor. I am Dr. Chris Baker, here to talk to you today about treating child patients without sedation and without general anesthesia, GA. You know, our specialty of pediatric dentistry in resident training, pretty much nationwide, has incorporated more and more intense training in sedation and GA in behavior management strategies. This is interesting because it actually gets you around the need for any behavior management strategies. So it's not exactly, it's kind of an oxymoron, right? You can't have an unconscious patient that needs any behavior management. Now, sedation, of course, doesn't make them unconscious. GA does. And the sedation, that's a little bit different animal. But the point is this. The oxymoron, if we will, of behavior management and sedation and GA are actually opposites. And so we're going to talk today about actually getting around using sedation and GA, because in our specialty, we need to be able to give the child a really good basis for their future dental health. And I don't believe, in my humble opinion, as we say, that actually gives them a very good basis. Let me talk to you about what our goal is then as a dentist treating children. Because whether you're a general dentist treating children or whether you're a pediatric dentist, you are then going to give them almost like a cornerstone of what the future will hold for their pediatric dental care first and future adult dental care. You know, the reality is, in being in the office setting provides an opportunity for the child, and more importantly for the parent, to be educated as they sit beside the child, to become more comfortable, to become better at coping, and to feel more supported by a caring doctor that you are. They don't even get to know that about you if you're not in a setting that they can be with you. Treating a sedated or unconscious child patient has become popular, but let's talk about why. One is Medicaid began funding those procedures for covered patients, and that was a boon for dentists to be able to take advantage of that and treat those Medicaid patients who were covered in that way. Also, parents are often frightened enough themselves to be afraid to watch their child, quote, go through something like this. Well, another reason that it became popular is that doctors can seemingly work quicker, thus increase the income, which is discounted greatly by Medicaid and insurance companies to start with. That's kind of funny, isn't it? Increase your discounted income. And the doctor can charge additional billing for the sedation or for the GA, although if it's in the OR, of course, then there's a fee for that. So, you know, either way, the reality is, let's face the fact that the discounts are kind of evening out any benefit to your ability to produce more. And let me digress here again. I said funny because, again, if you're not actually benefiting financially and the patient isn't benefiting and the parent isn't benefiting, then why are we doing it? Who are we? Right? So let's kind of look at this, because guess who does benefit? Guess who benefits? When you think about it, the insurance companies, including the government, the Medicaid insurance, they benefit. So who's the smart one here? Well, for the doctor, the advantage remaining would be then that they can focus on restorative treatments as needed on the general anesthesia unconscious patient, or sometimes on a sedation patient. Now, let me just tell you this. Yes, you don't need to attend to the education or the help in teaching coping, and you don't get to show your love, so I see those as big disadvantages, but you can focus on the treatment. Now, that part of you that is an engineer, that is and even an artist, that could be good. It's kind of like working on the dentiform in dental school, right? But the reality is that who we are? As patients who need all the love we can give, parents who need all the love we can give, parents who need to learn how to help their child cope, which you can teach, those are things that are a much higher level of dental care for the child. What about the future for that child? Let me give you some thoughts. First of all, when they go to the OR or when they are sedated, that tends to be found to be very repetitive for that child. Think about this. Dr. Stephen Wilson noted years ago in his study that more than 80% of OR patients return in 2 to 3 years for more OR treatment. OR treatment because it's covered, that's what the parents used to, and that's what they did before, and so let's just do it again. Interesting. What have we done for that patient? What about their future? Is that who we are? I have treated every single patient who presents for treatment and needs treatment without sedation or GA and with very rare nitrous. You might say, why? Because for me, again, educating and loving the patient and the parent is the whole point, so that their dental health future is more likely to be better. And it works. And the parents are very grateful to me when they sit with me and their child. They understand what's going on. They see what we're doing. They can't believe that we are so patient. Sometimes inside, we're not feeling as patient as we might appear, but the reality is they understand our love and dedication. And that ties them to us in a much greater way. And I have to tell you, I have had very, very rare decay, new decay in any of my patients I've treated, thousands upon thousands in 30 plus years. I don't have the recurrence. Why is that? Because the parents are more dedicated to bringing them back regularly. The parents are more committed to helping with the care once they see what needs to be done to, once they go to OR and, okay, it's fixed, let's help them wake up. They have no idea what you've had to do. They have no idea what it all looks like. Yes, I have referred out of the thousands. I believe it's 3, maybe it was 4, I'm not sure, to have GA. Why? That was due to parent insistence. And they are the boss for their child. I will try to tell them whatever I think would be best and why, and when they don't agree, guess what? They get to advocate for their child. Why did I refer? Because I don't do OR and GA treatments. Now, this is kind of funny when you think about it, because I'm a registered nurse, and I started my career in nursing. And when I was teaching at 3 different university dental schools, which include University of Kentucky, Louisville, and Connecticut, I was the attending in the OR. I was responsible for teaching those items of care, those types of care, those things about care that are required by the American Dental Association CODA to certify the program. Believe me, I know how to work in the OR. Believe me, I know it's fun to march in and be the attending and talk to all the staff and have your own music playing, whatever you want, trying to be the big cheese. It's fun. It brought me back to my nursing days because of the conviviality and the collegiality with the other people in the operating room, sure. But again, that's a great place to teach restorative, just like on the typodont or dentiform in dental school. But is that how we want to treat the patient? And that's what I'm questioning for you to question in yourself. And now I'm going to tell you another reason that I am making this video. I just read this article and I just felt inspired, I guess, to make a video for you and have you think about this one. This was in the July-August Pediatric Dentistry Journal, AAPD Journal. Factors associated with prolonged exposure to GA during dental rehabilitation under GA in under age 3 years of age. It's a long title, that's what it was. They reported that these patients are about 25% of the patients who had enough, in these patients, about 25% of the patients had enough exposure to general anesthesia that they were at risk, as per the 2016 FDA warning against such exposure, to have negative impact on brain development with long-term consequences. Of what do I speak? Specifically, and I quote from the FDA warning and from the article, this can cause widespread loss of nerve cells and suggested these changes resulted in long-term negative effects on behavior and on ability to learn and on learning. Wow. The FDA also warned that surgeries during the third trimester of pregnancy requiring GA should be performed only, of course, when medically necessary, but understanding that prolonged exposure for the protection of the unborn baby should be avoided for the same reason. Now, we're not treating patients in their third trimester of pregnancy almost ever unless you do OR dentistry with adults. But the reality is, do we want brain cells to die in our patients? Looking at these risks, I suggest to you, how about the cuddle coat, the papoose board? I know it's much maligned, but that's just silly. I've used it for over 30 years on patients who need to be safe. It is not punitive in my hands. It is merely safety. And the parents help me cuddle them up and sit right beside them. And it is marvelous when you have a child who is either too young, pre-cooperative, we like to call it, or too unable to be safe. And it's a perfectly wonderful tool. I understand the malignment that has occurred over the years, but I want you to rethink it because things are going to change in our profession. They are changing. Things are going to change in medicine, and things are going to change for your child patients. If they continue in the way we've been going, it's going to get harder, not easier, to treat these patients without being able to handle them in an office. Many of my colleagues are talking about the fact that they are having to limit their time in the OR because the ORs are pulling back on what they allow them to have and pulling back on the time available and charging more for it. So that eats into their profits too. Now, let me make clear, and you've probably heard me say this many times, you are in business to make a living. You are a dentist because you chose something that you wanted to help people, and that's wonderful. You are not a missionary in your regular day-to-day practice. You can do your pro bono, your missionary work anytime and any way you want, including in your practice. But your OR patients, just like any patients, should not automatically be patients that you're treating without any additional money. You've got to cover your costs and make a living. Okay. However, let's get back to the patient. So if it's not good for the patient, if young ones, who are often the ones that need OR, are going to have damage to their brain cells and not be able to learn as well and have as good of a life, who are we? Is that who we are? We are outstanding doctors. Let me answer for you. We are providing outstanding care, and we are loving the patients and the parents. That's who we are. Do you want to learn how to do this? I can teach you. You can make more money in treatment of children who need your outstanding care and your love and your commitment to being one of those outstanding, top-of-the-line people. I can teach you to do that outside of insurance discounting completely. I can teach you to do that without risking your patients and your own life with sedation or GA. Love and pediatric dentistry, this is a wonderful way to practice, and that's who we are. Dr. Chris, signing off.